So, good afternoon, everyone. I am presenting real-world data comparing effectiveness of immunotherapy alone versus immunotherapy plus chemotherapy and stage 4 non-squamous NSCLC with high PD-L1 expression. So, at present, standard of care in first line of treatment of metastatic NSCLC is either immunotherapy or chemo plus immunotherapy, depending on PD-L1 expression level, histology, and clinical scenario. And among the patient where PD-L1 expression is more than 50%, yet we are uncertain whether to give immunotherapy alone or immunotherapy plus chemotherapy, because there is no phase 3 data available which shows us that adding chemotherapy to immunotherapy in this subset of patient can give us any PFS or survival benefit. So this issue was addressed in this retrospective cohort study, which used Flatron Health database, which is a US database of electronic health record, to evaluate clinical outcomes using immunotherapy alone versus chemo plus immunotherapy in the patient with PD-L1 50% or more than 50%. And this data was collected from around 280 US cancer clinics. And the patients who were enrolled in this study were the patients who were having metastatic non-squamous NSCLC with high PD-L1 expression, which were initiated on either immunotherapy alone or immunotherapy plus chemotherapy between 24 October 2016 to 28 February 2019, and were followed until the end of a study, which was 28 February 2020. Primary outcome was overall survival, and secondary outcome were real-world progression-free survival, and were compared using Kaplan-Meier methodology, and hazard ratios were adjusted for difference in the baseline characteristic to reduce the bias because of difference in baseline characteristic in both the cohorts. So after 24 October 2016, around 24,000 patients were diagnosed to have stage 4 NSCLC. Out of those, 14,600 were upfront metastatic, whereas 9,400 were recurrent metastatic NSCLC. And out of these patients, there were around 520 patients who were adenocarcinoma and histology with PD-L1 more than 50%, where EGFR, ALK and other driver mutations were negative, good performance status, and who received either immunotherapy or immunoplus chemotherapy in a first line setting. So primary outcome was overall survival, and secondary endpoint was real world progression free survival, and predefined subgroup analysis was also designed to evaluate influence of brain metastasis or liver metastasis and smoking history in the outcomes. So immunotherapy alone cohort has 351 patients, and immunotherapy plus chemotherapy has 169 patients, and propensity score weighing was done to match the baseline characteristic to reduce the imbalance between baseline characteristic, and after that survival analysis was done. So to reduce indication bias in absence of randomization, a propensity score was estimated by regressing treatment assignment on key prognostic factors like age, sex, race, smoking history, performance status, metastatic type, and brain metastasis. And this propensity score was applied via inverse probability treatment weighing methodology. So in the group where the age was 65 or less than 65, it was noted that most of the patient received chemo plus immunotherapy, whereas the group where the patient age was 75 or more than 75, most of patients received immunotherapy only, and this difference was statistically significant. Similarly, the patient who presented with upfront stage 4 metastatic disease received chemo plus immunotherapy more as compared to the patient who presented with recurrent disease. Recurrent disease patients, majority of them received immunotherapy alone. And around 90% of patients in both the cohorts were smoker, and PD-L1 testing was done on DACO platform in most of, in 86% of both the cohort patients. And in the patient who received immunotherapy alone, 99% of patients received first line pembrolizumab alone. The patient who received chemo plus immunotherapy, 96% patients received PEM carbo plus pembrolizumab, and only 2% patients were there in immunotherapy alone arm who had received chemotherapy within past 6 months. So after propensity score weighing, overall survival and real world PFS was analyzed, and this propensity score weighing reduced the imbalance between the groups regarding to the baseline characteristic, and in each group after propensity score weighing, the standardized mean difference was less than 0.1. So coming to outcome, so primary outcome, overall survival, there was no difference in overall survival between immunotherapy and chemo plus immunotherapy arm, both adjusted analysis as well as unadjusted analysis. Similarly, for real-world PFS evaluation, there was no difference in PFS between the immunotherapy arm or chemo plus immunotherapy arm, both in adjusted as well as unadjusted analysis. But on subgroup analysis, there was significant overall survival and real-world PFS benefit in the patients who were non-smoker and who received chemo plus immunotherapy as compared to immunotherapy alone. But this subgroup of patients was very small. Only 50 patients were non-smokers in this cohort study. And interpreting this data should be careful because it was unadjusted analysis also. So coming to other subgroup analysis, to brain metastasis presence or absence or liver metastasis presence or absence didn't had any overall survival or real world PFS difference in immunotherapy or chemo plus immunotherapy arm. Median follow-up in immunotherapy alone was 23.5 months, whereas in chemotherapy and immunotherapy was 19.9 months, and median time to treatment discontinuation was around 8.5 months as compared to 7.3 months, and around 30% of patients in both cohorts received further chemo and immunotherapy after progression. So coming to conclusion, patient who receives immunotherapy alone are generally older and are more frequently having recurrent diseases. Upfront stage 4 patients and younger patients generally receive immuno plus chemotherapy, and there is no difference of median overall survival or real world PFS in the patient who receives only immunotherapy versus immunotherapy plus chemotherapy if PD-L1 is more than 50%. And real world PFS in immunotherapy alone showed a steeper decrease in first few months, but that does not reflect in impact on long-term overall survival or real world PFS benefit. In this study, immunotherapy alone performed significantly worse in no smoking stratum, but this data has to be interpreted carefully because the sample size was very small, there were multiple testing issues, and there was lack of adjustment for baseline characteristic. So according to this study, sparing chemotherapy in first line immunotherapy treatment does not appear to impact survival outcomes except potential in patient with no smoking history. Thank you.